my gratitude to Dr. Sanjeev D'Souza for giving me this opportunity. And I must admit, I am not an interventional nephrologist. We all know all guidelines in the world recommend that we should have AV fistula as the first choice for vascular access, followed by AV graft. Third should be tunnel venous catheter, and non-tunnel catheter is an option of necessity only. It is expected that 65% of all incident patients who are initiated on dialysis have got AV fistulas, and 85% of the prevalent patients on hemodialysis should have AV fistula as a choice of access, because that is the best way for dialysis, and the long-term primary access survival or the patency rate differs significantly. In fistulas, it may be 85% at 2 years. In graft, almost 40%, that is half of them after 2 years. But interestingly, in Europe, majority of the new and incident patients, almost 80%, start with fistula, but in US, majority, 70%, starts with AV graft, and minority are started on fistula for reasons obvious. They claim that possibly the clientele which comes on dialysis is older, the clientele which comes on dialysis has got more comorbidities. That is the reason attributed. Undoubtedly, if you see the survival of AV fistula vis-a-vis graft, there is no ambiguity that even at approximately 2 years, close to over 80% of the fistulas are functional. For fistulas, we know we are going from basics. There is a rule of 6, that is 6 weeks after AV fistula is placed, it should have a blood flow rate of 600 ml per minute. It should not be deeper than 6 millimeter from surface, and the diameter should be greater than 6 millimeter. If we look at the normal distribution of blood in the body, what proportion of cardiac output goes to different areas, to the arm approximately 250 to 300 ml blood will reach. Therefore, in a basal setting, the blood flow in the radial artery will be around 56 ml per minute. The moment you create a fistula, a day after, the blood flow through this is approximately 6 times to 7 times, that is 365 ml, and after 4 weeks, when you generally say that the fistula should be used, the average blood flow is 720 ml per minute. Likewise, it has got an effect on the cardiac status also. 14 days after creation of a AV fistula, there is a significant elevation in left ventricular end diastolic volume by 4%, fractional shortening increased by 8%, and cardiac output increases by approximately 15%. Why the cardiac output increases after creation of fistula? Primarily, it is a reduction in peripheral resistance. And when there is a reduction in peripheral resistance, to make up for the cardiac output, there is an increase in stroke volume and heart rate. And likewise, there is an increase in sympathetic activity, which is evident also. Now, if you see the upper arm fistula and the lower arm fistula, conventional, and look at the graft, you will find that the QA, that the blood flow through the fistula in the graft, if it is 0.7 liters per minute, in lower arm fistulas it is approximately 1 liter, and in upper arm fistula it becomes 1.8 liter. Accordingly, if you see the cardiac output, which is approximately normal here, in lower arm fistula there is a marginal increase, and in upper arm fistula the cardiac output has increased significantly. Now, when we make a preemptive fistula, in 160 of the 562 patients with stage 4 or 5 pre-dialysis, when the fistula is created, it was found that 17% had acute decompensated congestive cardiac failure, the risk certainly was higher in a proximal fistula. And the time gap between the creation of fistula and congestive cardiac failure was 51 days. So the risk of developing congestive cardiac failure is much higher, approximately 10 times higher, if the fistula is made in the upper arm. So if you are to see what is the risk of high output failure, you will find the upper arm fistula with a blood flow of more than 2 liters per minute, or increased left ventricular end diastolic volume when the fistula flow is more than 2 liters per minute. That is generally a strongest risk factor for developing the congestive cardiac failure. Now the contribution, if you want to see that the sympathetic also contributes to the increased cardiac output, the cardiac 10 dogs which are made areflexic by sympathectomy, the large AV fistulas are compared between controls. The cardiac output increase was 75% in areflexic dog, but if the intact reflexes are there, the compensation is 82%. It is only signifying that sympathetic activity also plays a role in increase in cardiac output. However, the cardiac output is not increasing linearly as the fistula flow is increasing. If this is the fistula flow, you find this is approximately normal fistula flow in the distal fistulas. This is the proximal fistulas, but once the blood flow to the fistula is more than 2 liters, there is a sudden rise in the cardiac output at this time, and these are the people who are becoming vulnerable for congestive cardiac failure. A corollary to that, the studies show that effect of closure of AV fistula on what happens in left ventricular dimensions. 20 patients with well-functioning renal transplant undergo 2D echo before and 3 to 4 months after closure of fistula. Fistula flow was assessed. The mean fistula flow was approximately 1800 ml. After closure of fistula, you find that the left ventricular end diastolic volume decreases and left ventricular mass also decreases. Now, what is the effect on pulmonary circulation? Whenever there is an increased cardiac output which is going to the lungs, the small vessels which are lying dormant, they open up, they accommodate this increased blood. Like if the ability of the normal pulmonary circulation to dilate and recruit unused blood vessels prevents the development of pulmonary hypertension in conditions where the pulmonary flow is increasing. But pulmonary hypertension in dialysis is unique form which is characterized by increased cardiac output and uremia-induced endothelial dysfunction. Undoubtedly, as the pulmonary hypertension keeps increasing, the risk hazard obviously keeps increasing. Now, pulmonary hypertension, it is found that approximately 40% of maintenance hemodialysis patients have got pulmonary hypertension. These patients who have pulmonary hypertension, they have got higher cardiac output, approximately 7 liters vis-a-vis 5.5. And if you compress the AV excess, in 4 patients they compress that, and you find that the systolic pulmonary artery pressure drops from 52 to 41, and it normalized in most of the patients following transplantation when the fistula is closed. Now, the contribution to pulmonary hypertension is due to endothelin and large left to right shunt predominantly. If you look at the endothelin levels in dialysis population, this is the control population, this is prior to doing HD, and this is after doing HD. You are only finding that there is a marginal increase in endothelin level after dialysis. Likewise, if you see the nitric oxide in control, this is people without pulmonary hypertension, you have got significant level of nitric oxide, and those with pulmonary hypertension, they have got less level of nitric oxide, which is implying that the hypertension is developing possibly due to endothelin and the low levels of nitric oxide. Likewise, if you look at the pulmonary artery pressure, this is before transplantation, what happens after transplantation. If you look at before AV closure, and this is after AV closure. If you look at cardiac output before transplantation, after transplantation, and likewise before closure, it is only implying that most of these problems are related to high cardiac output or high blood flow. But there is a contrary data also which is appearing. This is the data which appeared in 2010. They found that 20 patients before and approximately 2 years after creation of fistula, they find that there is no increase in pulmonary pressure even after 2 years of creating of AV fistula. Likewise, another recent study published last year, 50 patients prospectively studied for good around approximately 2.5 months, and they find that 2.5 months there is no difference in development of pulmonary hypertension in these population. So there is a contrary data also, but what is appearing dominant, that people who have got increased cardiac output, possibly these people are vulnerable to pulmonary hypertension. I am skipping the medical management because of the interventional symposium what we are having. I thought whatever is available, we will talk about it. The best bet, if a person has got high congestive cardiac failure or pulmonary hypertension, is certainly to close the fistula. Well, this may not be possible in patients who are on dialysis, but this is certainly possible in patients who have been transplanted. So in them, this will be the best bet for management of this high output failures. If you look at the Parsley laws very clearly, the biggest thing is radius of the blood vessel, r raised to power 4. So therefore, to control all the problems of high output failure, you have to bring down the radius of the fistula. Second technique is a banding technique. Banding technique decreases flow by decreasing the radius at a specific point. You just band the fistula, make it narrow. Now the problems with banding are, if the band is too tight, it will cause poor dialysis efficiency or even excess thrombosis, and if it is too loose a band, it will not be able to alleviate the symptoms. Now, the best way, now you find that if you are able to do Doppler at the time of banding, and at that point if you find that 400 ml per minute you keep the blood in the fistula, or 600 ml per minute in the graft if you target, then you can achieve the aim, banding will be successful. There are other modalities like proximal AV anastomosis. As Dr. Bhalla was just mentioning, they were mentioning that if the proximal connection is made by putting a graft or making an anastomosis, you block the fistula, which is high output, and bring it little proximal. Maybe you can have to put a graft. The drawback is only the narrowing and stenosis can occur, because whenever you will interpose a graft between artery and vein, at the point of anastomosis, a stenosis can develop. Next option will be RUDI, that is revision using distal inflow, that is anastomosis between distal vessels, thereby reducing the flow. That means the proximal, if the fistula is there, you just go distally where the vessels are smaller and anastomose them. You can shelve the problem of high output failure. Lastly, a technique which has recently come in the last 3-4 years, that is the Miller banding technique, which is minimally invasive limited ligation. Basically, It's an endoluminal assisted revision and banding. What you do, it effectively treats high flow AVF showing both cardiac output and steal symptoms. What you are basically doing in this, that you are putting a balloon in the fistula. That means a 3 to 4 millimeter balloon you put in the fistula, you inflate the balloon and keep it there, and then tie the fistula otherwise. So that means I'll just show you a diagram. That means you have put through a guide wire a balloon. Now the balloon is here. That is what you want, 3 to 4 millimeter fistula, and over this, whatever is the residual, you band it over this. So these are just the photographs of this method. This Miller technique, Miller and all have published. They treated 183 patients who had high flow and steal phenomena. 114 of them had hand ischemia and 69 had congestive cardiac failure. All these patients had 229 banding procedure with technical success of approximately 99% or 98%, and there was a complete symptomatic relief in 109 steal patients and in all high flow patients. So as on today, what we can conclude, that the proximal fistulas have significantly increased cardiac output. The risk of congestive cardiac failure is higher if the blood flow in the fistula is more than 2 liters. Around 40% of the hemodialysis patients develop pulmonary hypertension, and which is predominantly high flow related. Both these complications certainly increase the risk hazard, and today banding, the Miller technique, appears to be the best solution for these people. Logically, there are no clear guidelines given for all these techniques, so therefore it is a clinical judgment, and whatever you feel best for that patient, you need to do that. Thank you.